My name's Chad Kleiner, and I'm the product manager here at Ossio. I'm really happy to be with you today. Thanks for taking the time out of your busy schedules to join us tonight, and welcome to our Ossio webinar. We're excited to share some updates with you, go over the OSSIOfiber material technology, and our exciting new small compression staples product. Tonight's webinar will be led by Dr. Selene Parekh and Dr. Bradley Lamm. Dr. Selene Parekh is a board-certified, fellowship-trained orthopedic foot and ankle surgeon. He is currently an orthopedic surgeon at the Rothman Orthopedic Institute and a professor of orthopedics at the Sidney Kimmel College of Medicine at Thomas Jefferson University. He's director of the Foot and Ankle Fellowship at Rothman. Dr. Parekh is known for utilizing state-of-the-art implants and techniques designed and developed to provide better treatments and offer limb salvage. Dr. Parekh also focuses on minimally invasive surgery and is a pioneer in the use of 3D printing techniques, total ankle replacements, and the treatment of foot and ankle conditions in athletes. He also leads the Fantasy Doctors, providing expert insights into sports injuries, and co-founded the Parekh Family Foundation, which helps to support the education and care of foot and ankle patients throughout the world. Dr. Bradley Lamm is the director of the Foot and Ankle Deformity Correction Center and Fellowship at the Paley Orthopedic and Spine Institute in West Palm Beach, Florida. He is also the chief of foot and ankle surgery at St. Mary's Medical Center and the Palm Beach Children's Hospital. Dr. Lamm is a board-certified podiatric foot and ankle surgeon and is the podiatric surgical resident rotation director at Harvard Medical School. So happy to have Dr. Parekh and Dr. Lamm with us this evening. Now, we have a stacked agenda to get through this evening. Dr. Parekh and Dr. Lamm will begin by going over their individual journeys with Ossio and using OSSIOfiber. Dr. Parekh is going to go over the science behind our material technology, and then Dr. Lamm is going to cover how he explains OSSIOfiber to a patient. We will cover the existing product portfolio before transitioning to talk about ache and osteotomy fixation options, and this is going to lead into a discussion of our new small compression staples. Now, throughout the webinar this evening, we will be stopping periodically to field any questions that you might have. As Beverly mentioned, please submit your questions using the Q&A feature on Zoom, and I will be sure to include your question during the dedicated Q&A time. Now, no one certainly came to listen to me speak tonight, so I will pass it over to Dr. Parekh.
Awesome. Thanks, Chad, and thanks, Ossio, for sponsoring tonight. I appreciate everybody making time out of their schedule to make it here tonight. So, OSSIOfiber, this may be something new, the small staple that brought your interest, or maybe you've been following Ossio for a long time. For me, I'd been following for a long time and actually was an early adopter over probably 7 or 10 years ago. But interestingly, my journey with OSSIOfiber began almost from the beginning when it was really just a concept. And back then, the introduction was really more of a potential wire made of OSSIOfiber that potentially could be used in foot and ankle. And since that time, we will go through in the evolution of OSSIOfiber later in this presentation, but I have slowly integrated some of the products as they've come along. And my introductory product was really their IPJ implant product, which transformed the way I could fuse IPJ patients and avoid metal. And then it went on to some of the other products that we'll talk about later on tonight. It's been fantastic to see OSSIOfiber's technology, which is a platform technology, make its way through bigger and more traditional implants. And to me, the future is really bright as to where this technology goes. Brad, your thoughts on your journey?
Yeah, so I too kind of early adopted it, but I got a call from Bob Barbarian and Luke Ciccinelli, who I'm friends with, both of them, and kind of introduced me to the product. And finally got a chance to feel it, and it's definitely strong. Like that was my first concern, is it strong enough, you know? And then, you know, after seeing some of the data that came out, I was like, wow, this looks very unique and promising, not just one of these resorbable type implants, you know, something that actually integrates. And I thought this would be a game changer. And after trying it and using it for, you know, about 4 or 5 years now, I've really enjoyed the product, and I look for bigger things to come for sure.
Awesome. Well, you know, a lot of you may be wondering, what is osteofiber, bone fiber, right? What is it? What does it mean? So we're going to talk about the science of this, and I won't bore you into great depths, but I want to touch upon a lot of things at a very high level. Chad, next slide. So when we talk about the history of biomaterials and orthopedic implants, I mean, to me, with somebody who's really interested in technology, it's been really exciting to see biomaterials evolve. And if you go back to the 1700s and 1775, that's where you saw the first K-wires being used. First metal implants with internal fixation was 1858. And then you fast forward to the 1990s when you saw the first bioresorbable screws develop. Now, they were fraught with issues, and I remember that in my training, that there was a lot of this excitement, and then it kind of died away because of the issues with bioresorbable implants. Well, then PEC came out in the 1990s, biocomposites came out in the 2000s, and Osseo, which is biointegrative, came out in 2019. And so you'll see why we emphasize biointegrative later on. But when you look at strength and natural bone regeneration, and you kind of put this on an X and Y axes, think about OSSIOfiber. It gives you the strength that you want out of implants, but it also gives you that natural bone regeneration. Unlike PEEK, unlike metal, which are different on when you graft them out, and unlike other biocomposites. So it tends to be in a class of its own in terms of incorporating strength and biointegration. Next slide. So what do we mean by this, and what exactly is osteofiber? So osteofiber is made of synthetic bone fiber architecture of fibrils in a bioresorbable polymer that is laid in different directions, and that allows it to have its strength. Now, these different fibers in different directions allow you also to come up with different geometries. And what started off initially as just an IPJ implant has now grown to geometries of staples. Now, the osteofiber integrates, it doesn't resorb. And what I mean by that is bone grows into this implant, and as it does, the polymer is cleared with hydrolysis. You can go to the next slide. So when we think about what happens over time, you put your implant in, doesn't matter what implant you have in, and as you track this over time, you got the bone on the left, the osteofiber on the right, the matrix. You start seeing the bone coming in, and as you track this over time, the osteofiber will start integrating, or the bone will start integrating and hydrolyzing the fiber, so that over the course of 2 years, you have full dissolution of the osteofiber implant, regardless of the type of implant you see in 2 years. And you're left with just bone. So patients don't have to worry about any prominent hardware problems. They don't have to worry about metal allergies, because this is metaless surgery. And this has been shown to be safe and a safe biological response. Next slide. So when we think about fiber orientation, it can be changed from implant to implant, and it can be optimized for strength, whether you're talking again from the IPJ, and if you follow these implants down all the way to the staples. And that allows this platform technology to have a lot of applications throughout orthopedics, throughout podiatry, throughout foot and ankle. So don't think of this as a technology just for the foot and ankle. It actually goes well beyond that, and you're seeing sports colleagues, some of the trauma colleagues starting to integrate this throughout the body. Go ahead. Next slide. So what's the data show on the osseo integration? Next slide. Well, first off, everybody takes a look at this and says, oh, this is just a synthetic material. How strong is it? Well, if you look at 0.0, osteofiber is stronger than cortical healthy bone, stronger than PEEK, and stronger than conventional bioresorbables. That says a lot. It's about 1.5 times the strength of cortical bone. So think about that when you're putting in these implants for different indications, that you're getting something stronger than cortical bone. It's obviously stronger than PEEK, which is used for a lot of different things in orthopedics and in podiatry, and up to 5 times stronger than other bioresorbable implants. Next slide. Now, when you track this out of bone formation or integration and the osteofiber biointegrating and going away, you see that they kind of approach each other. So the green line is the osteofiber starting to go away as time goes on and resorb, okay, or biointegrate over time. And then you see the bone in the gray starting to integrate into that implant. And really, they start around 12, 24 weeks. That's kind of where you see these plateau and get healthy, renewed bone. Next slide. So I oftentimes get from patients and from other surgeons I talk to OsseoFiber about what data do you have? Well, there was a clinical trial done with IPJ implants, 24 patients enrolled, and these patients were followed for 52 weeks. So doing a 52-week assessment for those patients who had IPJ implants for amateur surgeries. And when you look at the primary endpoints, 100% of these patients had clinically stable joints at the end of the trial. 88% had radiographic fusion at 26 weeks, 92% radiographic fusion at 52 weeks. And if you track this out to 2 years, 96% fusion rate. And that's pretty incredible with no hardware remaining. There's no side effects, no adverse effects that were documented or reported in this study. And patients reported dramatic improvement from baseline using these implants. And they're all satisfied with the implant and the procedure and would recommend them to others. Next slide. So what does this look like when you look at it radiographically? So these are MRIs of patients in this study who had a PIPJ fusion. The first slide, you're looking at the 1 year. There's the MRI showing that the implant's there, but you're seeing the osseointegration occur. And by 2 years, it's gone. And so you see the implant fully gone. There's no inflammatory response, which you saw with bioresorbable implants. Next slide. So when you look at this OsseoFiber on the top, biocomposites on the bottom, and you try to compare what does OsseoFiber look like compared to other biocomposites that are on the market, at 6 months, you start seeing new bone form in the OsseoFiber implants. You don't really see that in the biocomposites. And when you track that out for 2 years at the 24-month mark, again, you see OsseoFiber is fully biointegrated, no residual implant there, whereas in the biocomposites, you see almost no new bone forming, and you see a lot of that implant still remaining. Next slide. And it even goes to these suture anchors when you look at them cross-sectionally. So these are patients on the left who had OsseoFiber suture anchors implanted, and on the right, biocomposite suture anchors. And again, you're seeing in the B section of both, you're seeing a lot of the biocomposite implants still there, whereas for OsseoFiber, almost fully gone. So with OsseoFiber, you're seeing resorption, you're seeing no implant material left, tissue ingrowth is present, advanced bone replacement is present, and zero inflammation. And that's one of the other big things that everybody needs to be aware of. Unlike what we used to see with resorptive implants and that sterile abscess or that sterile inflammatory response, you do not see that with OsseoFiber. It really integrates. Next slide. And this translates even to plates. These are OsseoFiber plates in an animal model, looking at these from 13 weeks all the way to 104 weeks. And you can see that implant is integrating over time. And if you track this out, you see at the 13-week mark, the implant's thickness. And by 104 weeks, that implant is not only gone, but the thickness of the cortex has been restored. It's not thicker than other parts of the cortex. It's not thinner. It has been restored. All right, so it remodels back down to cortex by 104 weeks. Next slide. So at this point, I think we're going to open it to questions on anybody who may have thoughts or ideas or questions about the science of osteofiber.
Yeah, so I think continue to as questions come up, feel free to use the Q&A feature. We can stop periodically throughout this presentation. We have a question here, Dr. Parekh and Dr. Lamm. I don't know if you can see that. Will the osseointegration occur even if bone does not heal? I.e., if a non-union presents itself, will the implant remain in portion?
So it really depends, right? When you think about any fracture or a fusion, that so two things. You got to remember the surface area of the healing, okay? Where the osteofiber is present, if it's crossing the fracture site or the osteotomy site or the fusion site, I've always seen it go away over time. I haven't seen it stick around, even if you developed a non-union or partial union later on. When it spans the fracture or spans the osteotomy like a staple would, I certainly don't see it remaining, even if the procedure or that fusion or osteotomy didn't heal.
Yeah, and the good thing is that you can still go back in and do some other fixation method if you need to down the road, because it is basically becoming bone. Good, good.
Great.
All right, Chad, I'll go ahead with the how do I explain osteofiber to patients? Yeah, so this is these conversations you have to have with patients. Some patients come in, they're excited, they found me through the website of kind of osteo website, and they're interested and intrigued about no metal fixation. Some patients I offer to them because I feel like it'd be a better option than having some metal implant. Next slide. And then I usually tell them, okay, well, what is it made of? That's what patients want to know. And basically, I explained to them as Selene said that, basically it's, I say it's kind of like carbon fiber metal. It's basically, a man-made calcium that's woven together, basically like kind of carbon fiber metals woven together, which makes carbon fiber thinner or smaller, but very strong. So that's how I explain it to them. And that, of course, it becomes their own bone over a 2-year period. So that's what I explained to them, and that it's just as strong as some of our other implants we use. It just becomes bone over time. Next slide. The other thing I tell them is that this isn't something new. They're not a guinea pig. This is something that's been proven in the data, as Selene that you're not going to get a reaction, you're not going to get an infection type issue or rejection from this implant. So it's something that you don't need metal, that you can use this osteofiber to fixate and hold the bones strongly together. Next slide. Yeah, the other thing I tell them is, it's still the traditional surgery that we do. We just don't use the metal that we used to use. We can use these osteofiber implants to do the same procedure that we used to do with metal. So next slide. So then I kind of explain to them, hey, well, here's a photograph or a slide of a patient who had, this bunion procedure done, an Aiken and a first metatarsal osteotomy with osteofiber, versus the previous slide where you saw all metal for both the first metatarsal osteotomy and the Aiken. Next slide. And then I tell them it just becomes bone over time, and it becomes their own bone. So that's very pleasing to patients that they wouldn't have any kind of metal implant left over. Next. And then, it's all natural, and patients really love that. As a surgeon, I really like it. The only trouble is sometimes seeing it on the x-ray, because it does incorporate and becomes bone. And so you're like, wait, what did I do here? Kind of thing sometimes. But anyway, let patients love it because it's all natural, and they really, it's not a hard sell. It's not a hard sell. Next. All right.
All right.
Pass it
So,
back over. Yep.
yeah, so we're going to talk about the OSSIOfiber portfolio because the company's been around for a little bit of time, and what started off as just, oh, I don't know if you guys heard me. Sorry about that. What started off as as an IPJ implant has grown since the inception of this company. Chad, do you want to move over? Okay. So if you look at the upper left side, this is the OSSIOfiber IPJ implant. It comes straight or curved, and it comes small, medium, large. It's cannulated, and it allows you to be able to capture bone in the IPGA, whether straight or curved, and not have to worry about artery irritation. And as Brad mentioned, if it went on to a painful non-union or if it went on to an infection and you need to go back in and do something, you easily can. And this was kind of my gateway into OSSIOfiber. Um, After that, if you look at the middle here, these are the nails, the OSSIOfiber nails, which come in 4.0, and I think those are the only sizes. Does it come to 3.5 as well? Chad?
A 3.0 and a 4.0 cannulated nail. And then we have a
Yes.
2.4 solid nail.
Yeah, so I've used the 4.0 before. And this is nice to use. Even the 3.0s would be nice to use. I haven't had a chance to use it yet. But when you want to kind of spike a hemitalar allograft, or you want to put it across an osteotomy site, or for me, I use these nails routinely for my MIS bunions. And sometimes I'll use one metal screw and then the rest osteofiber. Sometimes I'll just do the osteofiber implants. So that's been nice. On the upper right-hand side are the screws that are available. And we use this routinely for our medial mal fractures, for Liz Franks. I've used this for prophylactic screw fixation after for total ankles. I mean, it's just wherever you would use a metal screw, you could use these osteofiber screws. Um, Osseo is also entered into the anchor space, and you see that in the bottom, that long handle. The osteofiber anchors at the end of it. This is a really nice anchor as well. It has 4 needles that come already loaded onto the implant. Two of these needles have sutures on them, and the other 2 have a fiber on it. So again, very versatile for individuals who want to do different things with their anchors. It gives you all the options you want, but you can also cut out what you don't want. And then finally are the staples. We're going to be talking about small staples later on in this presentation. But the staples come all the way from the large staples that you're used to in the metal versions. But here it's osteofiber, all the way down now to a size 9 staple. And so the portfolio has continued to grow over time, and I think will continue to grow into a lot of novel spaces. And as we appreciate more and more that patients can have allergies to implants, I think we have to be open to using some of these novel materials, number one. And number two, I think I've seen in the last 5 years more and more patients asking for no metal for their surgeries. And again, this is a great way to introduce you to osseo if you're looking for something like that. So with that, let's talk about some of the challenges of existing Aiken fixation offerings. Now, I don't know how many years many of you in the call have been in practice, but next slide. I've been in practice. It sounds weird because I'm making myself sound old, but back when we used to do chromic gut fixation for Aikens. Now, back then, I wasn't routinely taking pictures in the OR, so I don't have any pictures of it. But if you look at the upper left cartoon, this was the frustration of suture fixation for your Aikens. And you would try to make 2 holes that met in the osteotomy, fish a suture through it, and it was just painful to the point where you didn't really want to do an Aiken if you didn't have to. It was something that you would really unwillingly do. And then over time, people started using some wire fixation, not perfect, but okay, a little bit of progress. And then as technology developed, people started using K-wires, which you see in the lower left-hand side, different screws, which you see in the upper right-hand side and in the center here. And then some people started using some of these metal implants with or without K-wire fixation. But as you all know, metal you can feel, especially if you don't have a good soft tissue envelope. And depending on where you put your fixation for an Aiken, especially if you put it medially, like most of us will do, that can cause problems down the line with shoe wear. And so it's been great to see this implant now available. Next slide. All right, Brad.
Great. All right. So next slide. So I'm going to discuss this new OSSIOfiber compression staple. Dr. Parekh and I worked on putting this together and working with Ossio. It's been a great development, and we're going to show you our early cases here afterwards. But we have a 9 and 11 staple with 10 millimeters as the length from top to bottom. And then we have these little inner barbs that kind of grab the near cortex. And of course, the tapered ends so that it's ease of insertion. Next. So basically, you can easily insert this by hand from, say, the bottom left pitcher to the bottom middle pitcher, basically pushing it in there. And basically, these are 6 millimeter tapered distal legs at a 3-degree taper. And basically, they're kind of chamfered, so they can slip into the into the drill holes pretty smoothly. Next. So the barbs allow for gripping that near cortex. And so basically, after you get it down to what you see there in the middle of the screen, you just do a light tap with the tamp that's supplied, and it gives you that compression. Again, I feel like it's clinically a good amount of compression, but not too much. It feels solid, doesn't feel over compressed like some of the nitinol type staples I've used for the Aikens. Next. So this is what comes in the pack, your drills, your wires, in case you want to do a temporary fixation of your Aiken, the drill guide, the tamp, and of course the inserter. The inserter is nice because you can visually see when the staple is fully opened to the 90-90 degree. It shows you on the actual inserter where you twist it, basically that 180 degrees to next. And then what's a nice advantage of our drill sleeve is we have these windows. So once you do your drill holes for both arms or both legs, then you can insert it through the windows, which allows you easy visualization to ensure that you get the staple where the drill holes were. Next. And this is just showing you that our drill holes have a countersink. This countersink is special so that the actual staple is countersinked at the basically at the apex of the staple where the bridge of the staple is. It's a little thicker there to make sure that the implant is strong, and that thickness is accommodated by that kind of reaming of the drill. It has a stop on it on the guide, so you can't over ream. It reams it to the diameter required for the staple. Next. Basically, it's strong. We did some, basically force testing, and, over 1 million fatigue strength tested, over 1 million cycles to ensure that it was reliable in strength over time. And definitely stronger in this than the competing materials. Competing materials. Next. Yeah. And then basically, it is the first kind of non-permanent compression staple, which is pretty cool technology that, it maintains that compression and then becomes bone over time. Next. And as Selene talked about, it really becomes the bone. It doesn't make extra bone, as shown here in this the sheep study that he mentioned earlier. And after 104 weeks in that in vivo study, basically became that new cortical margin, which is what the staple is going to do for us as well for the Aiken. Next. And again, nitinol is over 50% of nickel. So this is nickel-free, no worry, still the compression. And again, as we mentioned, there's no concern on allergies here. Next. So if you follow some of my fellowship that I did and some of the publications, we talk a lot about Cora, and that's important for the Aiken osteotomy. So to talk about kind of planning purposes, the center rotation angulation. This is from, of course, Dr. Paley's work. Next. And so we can look at this in foot and ankle as well. And in foot and ankle, we have, angles and distances and, measurements. And, some just cut the bone, shift it, fixate it, but you really should look at where the deformity lies. Is it a proximal Aiken you need to do? Is it a distal Aiken? Is it a central Aiken? And by measuring the angles, you can determine that. Next slide. And so, again, if you do the osteotomy at the Cora, then you can correct the proximal and distal axes. Next. So here's just an example. This is a proximal apex or proximal Cora due to the measurements of the joint orientation angles. And so this would be a proximal Aiken we'd want to perform to correct the deformity as we desire. Next. So I'm going to show you a video here of a proximal Aiken with the OSSIOfiber compression staple. So basically, medial incision, take out your medial wedge. Again, this is the proximal Aiken. Closing, you can fixate it if you want with a wire that's provided in the set. And you can choose a 9 or 11 millimeter staple. I've used both, and both seem to be very successful. Just depends on your anatomy. So you drill your 2 drill holes on either side of your osteotomy for your staple. And then these are the countersink drill holes as well. Load up your staple. Again, this is illustrated on the inserter, kind of how to turn it to make sure you're at 90. Put it through the windows, as I mentioned. You can basically push it in most of the way, and then you can release, of course, the staple inserter, and then you'll be able to tamp it in the rest of the way where the barbs connect with the near cortex. All right, next slide. All right, so these are our early cases. Let's see. All right, so I'll go first. This is one of my cases here. Again, this was recently released. So this is next slide, just an osteotomy, medially based wedge. I use just oscillating saw. Next slide. Remove the wedge. Next slide. Close the osteotomy. Next slide. There's just showing it closed. I don't use a temporary wire. You can if you'd like. I just hold it closed. Next slide. And I just want to show you a video. I insert the distal drill first, and you can see there's a stop on it. It stops at the end. Yep. And then next video will show insertion or my reduction method of pulling the closed and holding it. And then I'll insert the second drill to drill for the next leg proximal. And then your preset for your staple. Next slide. And it's just a different view showing removal of the drills and then insertion of the staple, kind of from the top down. You see the windows in the drill guide here, allows for ease of insertion of the staple. So I want you to watch this, how I insert the staple. You find the ends, the window, it slides right in. Yep. And then what I do is I manually push it in until it hits the barbs. And then I'll hold the staple inserter and remove that. And then I think it's just 2 or 3 tamps, and then it seats nicely. So, yep. And there you have it. Okay.
Right. And so this is a patient of mine. She's in her 60s, comes in to see me, and was offered a proximal fusion type procedure, Lapidus type procedure by somebody else, came to see me, and I said, you have this rotational deformity, a large IM angle, but we can do a proximal osteotomy. I tend to still be a fan of the man osteotomy, that proximal crescenteric osteotomy, which many have abandoned. But I do think that Roger was correcting rotational deformity without really even knowing it. But in any case, I did that and then did a additional Aiken. And this is 1 day post-op, and you can see the alignments there. You can barely see the osseo implant. And so far, she's about 4 weeks out from her surgery. This X-ray was only a day out, but she's done well. Next. Here's another patient of mine. Patient has midfoot osteoarthritis, but also has a bunion that's really painful and wanted this corrected, has a slight rotational deformity as well. And although we offer a lot of MIS surgery, I like to kind of play around with different technologies and techniques. It's great for the residents and the fellows to see different ways of doing it. So next slide. So well, you'll see the X-ray later on, but approximately I did a different metal implant for the distal metatarsal osteotomy. But for my Aiken, I find that metaphyseal diaphyseal junction, I like to hold the toe in neutral alignment when I do that. And then I figure out how much of a width I want. And I make that second cut parallel to the nail bed. And then then I take out the bone, reduce it. And then like Brad said, I'll put the guide on. I actually like to put the proximal pins in first because you don't have a lot of real estate proximally. I always put the proximal one in first, then the distal one, take all of that out. And then you can insert the staple. The loading of the staple is fantastic. I've done almost every other staple in the market, and this one by far is really easy and nice to use. To insert, you feel like you have good control. You tamp it into place, and you enjoy results. Next slide. And this is what that X-ray looks like. All right, next slide. All right, Chad.
All right. Now would be a great time to take a look through some of this Q&A that's coming in. Let's see. One question for Dr. Lamm and Dr. Parekh: when designing the staple, what's the thought process on partial barbs versus full barbs versus no barbs at all?
So this was a discussion we had at length, and the thought was no barbs at all. How do you really get that fixation if you're trying to get a little bit of that compression in there? So having some barbs makes sense. Having it at the more proximal cortex of where you're working makes sense than having it at full length, because if you have a full length, sometimes it's harder to get that implant in. And if you see, we were looking for a press fit in a circular hole. If you have barbs in there as well, it can make it that much more challenging. So it's nice to get that initial insertion with no barbs and really capture it with the barbs as you really get towards the bridge. Brad?
Yeah, I totally agree. I think as you know, our videos show, you can just push it in by hand down to the barbs, and then a couple taps and the barbs engage the near cortex, which gives you that, non-loose pull out, or you're not concerned about pull out or loosening of that staple at that point. So you have the compression of the staple trying to rebound, plus you have the barbs holding the near cortex. And I've even broken the far cortex in these Aikens with my saw and still feel like the staple's holding it stoutly, and I don't need a second point of fixation after that even happens. So I feel like the barbs really helps to maintain that position.
For both of you, have you done MTP fusions with OSSIOfiber staples? If so, what kind of configuration are you using for those procedures, and what would the post-op protocol look like?
Brad, you want to hit that first?
Sure, yeah. Yeah, no, I think it's a reasonable option. I mean, also not only the 9s and 11 staples, but they have I think 15, 20, 25 staples as well, which are our larger staples that Ossio offers. So you could use even a combination of those two for first MPJ fusions. I know I've used it for TMT fusion, Ossio staples, which I think I used maybe a 15 or something like that. It worked really nicely. So yeah, these we can use in various indications and in foot and ankle. And you really don't change your technique, you don't change your post-op protocol, you're just using a different device. And I think it's, as we've shown, it's very strong, and you can feel secure that it's going to work the same as the metal. If you're kind of an early adopter like Selene and I, we use a little metal, little osseo, and then we get more comfortable and use more osseo. So that's kind of some of the things I've done in my practice. Kind of what do you think, Selene?
Yeah, so it's actually, you're so right. A little osseo and then metal, and then you kind of transition as you get more faith. I had transitioned my MTP fusion patients to three metal staples before osteostaples came about, and now I do three osteostaples. I use a 20 mm staple. I do one medial, one dorsolateral, or a dorsal medial, one dorsolateral. So you get this triplanar fixation. It works great. I let them walk on it immediately in a post-surgical shoe. I do keep them in that shoe for 8 weeks, and it works really well.
Great. For an Evans osteotomy, are you seeing any short-term or long-term challenges with the prominence of the osteostaple bridge across the osteotomy and bone graft?
I have not. And I would venture to say that even if you did see any prominence, which I have not had any problems with it, remember, it goes away over time, right? As this biointegrates, that irritation will go away. So I've not seen a problem with it, but if you did, I would just hang tight.
Yeah, I've used them for Evans, and works nicely. And yeah, it is prominent at first, but not something more than a typical uh, four 4-hole plate or 2-hole plate you may use. So it's not more prominent than typical metal implant. And as the animal study showed, and we showed, the data proves that it becomes more the cortex, not an extra cortex.
I mean, I've done it even on my dorsiflexion first ray osteotomies, and I put one or two staples on it, and healed great. And it's amazing. Patients are just fascinated to see that their surgery has been performed and they can't see any metal on the X-rays. I think that's really cool.
We have a question here about asking about the thickness of the bridge of the staple. Either of you want to comment on perceived thickness?
I don't think that there's a problem with perceived thickness. We tried to make it contoured so that you don't have any rough edges. And then we tried to sink it down, countersink it a little bit, so that any perceived thickness somebody may have, as this tamps into place, nestles kind of right against the cortex. So again, I have not personally had any problems with it. Certainly nothing more than metal staples, oftentimes much less than that.
Yeah, I totally agree. I think we wanted to make sure that it was made in a fashion that's going to be strong, easy to insert, and also low profile as much as possible. And I the half a dozen or a dozen that I've done so far on the Aiken, I don't feel it post-operatively once you close the skin. It really does nestle nice against the bone, especially since it's countersunk. And again, over time, it's going to get less and less prominent.
We have a question here about the pricing of these implants compared to metal screws or staples, and if hardware removal is a factor in kind of rationalizing price differences.
Brad, you may have more
Yeah.
also that.
Yeah, I think I mean, I use them at our surgery center that we have here. And so I think it's competitive pricing to the metal implant. So pretty much similar. The other important thing is to hospitals, they're always worried about kind of, cost of implants or, readmissions or resurgeries, that sort of thing. So you definitely could sell it, that way to your committee or to your hospital, that hey, this is something that not only is good for the short term first case, but it can avoid problems and further cases down the road.
Yeah, I've used it in the ASC setting, in the academic setting, in the private practice setting, in the hospital setting. I think more than anything, the health system or the system you're in obviously negotiates it out, but I don't seem to have ever heard it being a problem in terms of pricing. And then not even to the point where I've had to say, well, I can avoid hardware removal, so it's really worth it. So I don't even think it necessarily gets to that point, but you certainly can use that and leverage that.
Yeah, I agree.
And either of you talk to kind of the comparison of this staple versus nitinol staples, strength, and I guess how OSSIOfiber is able to accomplish strength versus a nitinol staple.
Yeah, so
Go ahead, Brett.
yeah, great, thanks. So I think, just feeling it, if you get a chance to, do a lab or have one of the representatives show you the staple, I mean, it's extremely difficult to break with your fingers or, it's very strong. And so, if I have something equivalent to, a non-metal equivalent, I think, it's a game changer. Patients are going to choose this, 99.9% of the time out of 100 that they prefer something to be, biointegrative like this and not have any, metal footprint. So I think in the Aiken for sure, I'm not sure strength is something I'm overly concerned about. And I think even in the other osteotomies or fusions we mentioned, it's showing that it is superior, or not superior, but equal to all the metal implants we're using.
Yeah, I mean, I routinely use these implants, the staples specifically for MTP fusions, TMT fusions, triple R3DCs, obviously not the subtalar joint, and have had no issues with it. I was an early adopter of nitinol. I loved nitinol, but I am seeing more and more metal issues, reactions patients are having. And I've had multiple patients who've already come in saying, hey, I don't want any metal. And so I started using the osseo staples in those cases, and I'm all in now because it just gives you the success for your surgery that you want, and you don't have to worry about it. And you can actually see the healing occur, right? There's no metal blocking your visual on the osteotomy or the fusion, which is awesome too.